go through a brief introduction about bias overall. Bias in general is a preference, as in I prefer dogs over cats. Everybody has preferences, but there may be some that we're not aware of or that we don't really want to admit to. And the way it comes out, one of the things I did a lot of for this project was I read a lot of psychology and a lot of different theories. And there's a psychologist from Yale, John DeVideo, who does a ton of work in this area, and especially looking at intergroup relations and thinking about how is society structured, how do we interact with people, and especially about how do we interact with people who are of different groups than us. So in each society there's different groups, and you're likely to be more favorable to your own group. I'm always more favorable to my family than anybody else, just because they're the most in-group that I have. And so this kind of in-group favoritism, that people who are like you, you're more likely to be favorable to, it's based on more fundamental survival strategies. And today, especially thinking about racial biases, the thought is that most biases fall into this area, that we're not necessarily against another group, but we're more self-focused and interested in our own group. But it can go into negativity towards other groups. In the psychological literature, this is called outgroup derogation. So if you see things as threats, if you see differences to in-group norms, you might have more of that active hostility towards a particular group. All right, so why do we have different relationships? So in all society, there's some hierarchical structure. There's some groups that have more beneficial, a higher status group, and a lower status group. And it's usually based on what's seen as ideal within a particular society, creating somewhat of a power imbalance, and then leading to different things to maintain the hierarchical structure. So stereotypes, prejudice, discrimination, and then leading to the lower status group having that increased stress, increased vulnerability, because they're not in that favored group status. So what do we have in the U.S.? So it took me a long time to find an actor under 40, a white actor under 40 to put up here. So the most advantaged group is based on a lot of different things. In the U.S., it's those who are younger, those who are male, those who are white, with a higher socioeconomic status, those who are thin, those who are attractive, and those with a straight sexual identity. So that's kind of, in this society, that's kind of what everyone else is compared to. Chris Pine, yes, Captain Kirk.
Yes, Captain Kirk, that's what I thought.
Oh, yeah.
All right, so how does this play into perceptions and experiences specifically in healthcare? So medical providers usually belong to a higher status group, so that perception, trust, satisfaction may be affected by different power structures and different social structures in society, and it may affect how compliant patients are with treatment, visits, things like that. And then also the disadvantaged groups in society are more on the lookout because of that structure and because of that power imbalance for things that they might experience more, and so they're more likely to perceive bias in healthcare. And again, with that differential between a provider and a patient, that sets up on how visits are perceived and how interactions are perceived, leading to differences in miscommunication, misunderstanding, and it can be high between disadvantaged and advantaged groups. So this isn't necessarily, well, I'll tell you a story about different questions asked in a visit. So in any standard visit, you're asked if you feel like you're going to be harmed, if you feel threatened, if you're worried about violence. And so usually when I go in for a visit, it's pretty standard. I feel like the questions are asked that people are assuming no as a baseline. but a while ago I was moving and I ended up having a bizarre accident with a bungee cord, and I fractured my cheekbone, scratched my eye, and so I went into the emergency room with my husband, and rightly so, he was asked to leave the visit, and they went through those questions, but now the expected answer wasn't necessarily no, and so it was just a very different experience and a different way of hearing those questions when they really thought that I was being injured or abused by somebody else. And also, I perceived like different looks at my husband, like during the course of the visit when he was brought back in, that they were really staring him down and making sure that he wasn't the one that did that to my face. All right. So the next topic, so I'm kind of going rapid fire through a lot of different psychological concepts, but I wanted to give kind of an overview of all of those to understand the difference in the literature of the bias that has been found in healthcare. So I'm going to talk a little bit now about cognitive processes. There's generally two different lines of thinking. Either it's an automatic kind of process or control process. So when I drive, when I ride my bike, I'm using automatic processes. I've done it thousands of times. I know how to do it. I don't have to think about it. So there's some set of associations that I have in the back of my mind that I can call upon without much effort. In the controlled one, it's more of an attentional response. I have to think about things more. I have to actually decide to do something. And you can use this controlled response to inhibit an automatic process, but it takes some resources. It takes some cognitive resources to say, I'm going to stop. I'm not going to do what I think I ought to do or what comes naturally to me. I'm going to go back and do it differently. So that automatic cognitive process leads to implicit bias. And so this again is on that unconscious, subconscious level that you may not know that you have. Again, it can be activated when you use shortcuts, when you have a lot going on and you just need to categorize something quick and understand a situation in a short amount of time. It can activate stereotypes that you might not even know that you have, that maybe probably started in childhood, and the more uncertain the situation, the more those automatic systems are likely to be activated. So one of the things that I didn't realize when I started this research is how much implicit bias I had. So I'll get to it a little bit later and how that's measured. But I took a bunch of different tests, and it actually turns out that I have a lot of implicit biases that I didn't realize. And one of those is against women. So most of my life I've been in kind of a male-dominated field. I was a math major in college. I went into philosophy where it was mostly men. I went into statistics, also mostly men. It was only when I went back into epidemiology and worked in health disparities where it switched and I worked more with women. But when I think about it, when I was growing up, my mom, also very anti-woman, like would say, oh, those women are doing certain things or doing things outside of what she thought was normal for a woman's role to be. And so that somehow got into my subconscious as well, and that I did things differently in a group of women than in a group of men, which you might do even without an implicit bias, but it took me back in thinking about how do I interact with people, how do I treat people like in meetings and in different scenarios. So it does take some interesting, it does lead you down interesting paths when you start looking into what do I think and what are my automatic preferences. All right, now that's contrasted with explicit biases. So these are things that you know that you're biased, that you have a bias, and you know that they affect your interactions with others. And these are part of that control process. So one of my biases is I'm trained as a statistician, and I'm biased against people who don't have that training but still do statistics. And I know about it, and I'm working to change it, but I look at things more carefully. I look at articles more carefully. If it's by a non-statistician, grants, things like that I just give more scrutiny to. And that's something that I knew about, that I have known about, and so it's explicit. It's in my everyday knowledge. And one thing that I found so interesting in some of the bias literature, and we'll get to it in a minute, in healthcare, was that the different tolerance for different explicit bias changes. So in general, we have a more politically correct society that doesn't tolerate having explicit biases against groups. And that's especially true for racial bias. But what's interesting is it's actually not necessarily true for people who have a bias against obese people. So people actually will admit to having that bias in rather large numbers and feel that it's okay to express that view. All right. Now the next thing moving into is how do we measure bias? So we think that bias may affect how we're interacting with people. How do we know if we have bias? And what do we do to change it? So explicit bias, conceptually, it's not hard to measure. You just ask people, how warmly do you feel about the elderly? How warmly do you feel about African Americans? So it's more of that direct question. But the problem with measuring it is you don't always get a truthful answer. And so the questions are good, but the answers have that kind of uncertainty about them, that you're not sure that people are being honest. Implicit bias is harder overall to measure, but maybe more accurate because it's harder to fool things that are measuring those automatic processes. And people have measured implicit bias by observing interactions, so looking for subtle, nonverbal cues, eye contact, different gestures, things like that. People have measured physiological response to interactions, so they'll measure heart rate, respiration rate to see how that changes in interaction. And then what I'm most familiar with is specially designed tests to measure implicit bias. And so what I've used and what I'm most familiar with is the implicit association test. And so what this does is it times you to figure out how fast you associate different concepts. So I'll go right to this screen. So in the test that we set up, we had two races, American Indian and white, and so we had photographs, and then we had different words representing good and bad concepts. So our good words were joy, love, wonderful, pleasant, laughter, happy, and our bad words were terrible, nasty, evil, awful, agony, and hurt. And so you go through, and if you're on the keyboard, you have your fingers on your I and your E keys, and you're kind of classifying these as fast as you can. And overall, it gives you a score. So we'll rate you from strong preference for one group. So on either end, you can have a strong preference for white, strong preference for American Indians, and anywhere towards you are about equal. So that's how it's scored. And they have tons of different tests that you can take. So this is how I know I have lots of implicit biases, because you can go take this test. And then people have used these different tests in a healthcare setting to say what biases might affect care, what biases might affect interactions with patients. And it turns out that almost all of them can. So there's been, most of the initial work was on that race bias, and it was mostly for African American versus white populations. And in some studies they found that not only did they find high levels of implicit bias, but that they found differences in how physicians made treatment decisions because of that. There's this anti-fat or obesity bias. Again, that was found, and they found high levels both of implicit and explicit bias, and that affected the communication with patients. Anti-aging bias, so this was a study that looked at medical students, that they found that they had a strong preference for people who were younger as opposed to older. And then some newer research has come out looking at sexual minorities and looking at bias in that. There's been studies on people with disabilities also. So all these things kind of looking at that implicit bias, what are our preferences and what are preferences that we may not know about. And this kind of just talks about kind of a summary of the literature that's out there. As far as implicit bias, that there might be these unconscious stereotypes, that different diseases might be associated with different groups. And then there's lower levels of explicit bias, but one thing that came out more common was that people felt that different groups would be non-compliant with the treatment, and that could play into the treatment recommendation. So if you think somebody won't comply with this complicated regimen, you might give them something else. And then there's some associations with clinical care. This has been greater in more subjective areas like pain control. And that, I think, in general, measuring pain is probably one of the most difficult things to do, because not only do you have differences in the way people actually feel about their pain, but you have differences in the way people interpret the scale. So when I think about the pain scale, and I think 10 being the most painful thing you can think about, I want to leave a little room at the top because I'm pretty sure I haven't experienced the worst pain ever. So I usually try to go down on the scale, but apparently you're not supposed to use half steps, so I tried to rate my pain as a 1.5 one time. That got thrown out. So I pulled this kind of visual of the different ways that different biases can affect health disparities in healthcare. And so this was specifically thinking about racial health disparities. And so they identified 3 different pathways that might affect health. And the first was a direct pathway thinking about explicit bias. So somebody who's had persistent discrimination, persistent prejudice, can actually have physiological and physical symptoms because of that stress, leading to different lower health status. But then they identified a couple of different ways physician, healthcare provider could affect that bias. And the one is in decision making. So if you feel that this group of patients are less compliant, then again you might do a different regimen than you otherwise would. And that wouldn't necessarily be bad if you knew something about that individual patient, but if you're doing it kind of as a general thing that this group is less compliant, so anybody from that group, I'm going to give this other treatment regimen. And then the other way is that it affects relationships. So it affects that communication, leading to negative feelings from the patient, maybe not wanting to come in, maybe not wanting to get care, leading to differences in healthcare use and health disparities. All right, so now I just wanted to go over a little bit about what we did in our study. So kind of taking some of the implicit bias information and showing our findings. So we have the implicit association test, and again we created a new one because we wanted patients that are physicians and nurses that look like people they would see. So we had pictures of both adults and kids who are American Indian or white. And then, so we randomly had each person who filled out the survey do one of these. In our initial hypothesis, so the physician that we were working with suggested that there's no bias towards kids, that all of the bias that he felt was towards the parent or caregiver, because who could have an implicit bias towards kids? And that's actually not what we found. We found that they were about similar, because again, it's probably more related to that in-group, out-group psychological process than the particular age of the person, as long as they're not too old. And this has been confirmed in other studies. There was a study that was done, used the implicit association test, and had pictures of African American babies. And they also found high levels of implicit bias or pro-white bias for that study. So the other thing that we did was we tried to look at explicit bias. And so we asked about different stereotypes, again thinking about whether parents and caregivers were less compliant, came in for less urgent reasons, and whether the care was more challenging. So we found a little bit, the largest agreement was with the less compliant, and then about 20% for the more challenging and less urgent. So some levels of that, but not to the extent of the implicit bias. So for that part of the study, we found the strong implicit preference for white adults and kids, some agreement with explicit bias questions. We tried to do vignettes, kind of mimicking clinical care, and I don't know that they were a really good measure because it's not what happens in reality, and just answering questions about it may not mimic the clinical experience. But we didn't find any difference in race based on the clinical vignettes. Actually, we found an opposite difference, that they were more favorable towards American Indian children in the vignettes. And then we did not find an association between the stereotypes and IAT score. But again, if you read the psychological literature, the idea is that those are on two different levels. So explicit bias has a different cognitive realm than the implicit bias. All right, so the other thing I wanted to do was talk about our community focus groups. So we went into all of our different communities in South Dakota and Minnesota, and we asked parents or caregivers who had taken their child to the emergency department within a year, and then we also had meetings with tribal elders or community leaders, depending on the community. So I wanted to show this, this is mainly just thinking about what's going on from the patient perspective, and kind of what's their perspective of care, what do they feel the barriers are to getting good care for their kids, what are the facilitators to getting good care, and what recommendations do they have. And I hadn't done this type of qualitative research before, so I didn't realize how in-depth it was. So you have these transcripts from all of these different groups, and then you go through all the transcripts, and you categorize each statement that somebody has made into different areas. And so these are the different areas that we came up with. One was transportation, one was determining when to take a child in, and then a lot were related to, kind of classified everything as environment. So what's going on at the visit, so what the physical environment, including the room, and then emotional and social, like those interactions with care providers, including perceived education, inequity, judgment and prejudice, communications, and then cultural competency. And then also within that environment, we had some economic concerns, and then staffing, like level of staffing. So I picked out a few of the representative quotes from a number of different areas, mostly focusing on that interaction piece. So the first one was cultural competency. The first one was a barrier that said if you had a severe medical emergency in the hospital, it was hard to burn sage and hang up goat feathers and things. But another person had a very different experience. They said, we've had a couple of experiences where we've had family members, and before they passed, they let us come in and do our cultural practices, so they were okay with it. And then a recommendation, but it would be nice if they could see into the actual culture and what it's really there for and what it really needs and stuff. So then we had a lot of comments about communication. So a barrier, one person said, and attitudes and comments is another one. Like, you can't tell me that, oh, I wouldn't have brought my kid. Of course you wouldn't, you're a doctor and you already know that. You know I don't know that, and that's why I'm here. And then a facilitator, one person really liked the receptionist. They said the receptionists up there are pretty welcoming. They kind of, get you what you need, what's going on, and they get your information right away. And then a recommendation for communication was reassuring the parents, while you're in the waiting room, like give them some check-in times or go and check on them and the child. So kind of a lot of people talked about the feeling of being forgotten. So that was the recommendation. And we did have a lot of comments about inequity, judgment, and prejudice. We didn't have a facilitator for that. But a barrier, one person said, a couple of my kids are darker complected, so I always make sure that somebody goes in with them when they take their kids in, because I've seen them be treated differently. So So the perception that they wouldn't get good care unless they came in with those kids. And then a recommendation, well, it'd be nice if there were more Native Americans, especially nurses, and seeing that their in-group was representative in the staff. Then we had a lot of economic comments. When you're poor, you don't have options. When you're poor here in your American Indian, you have even fewer options. So again, feeling that difference in socioeconomic levels. And then a recommendation, someone said, I think it starts at the top of policy because I know things cost money and I'm well aware of that. But at the same time, there's an invisible line with the haves and the have-nots. And for the have-nots, the world is really hard. And there just has to be a place where there's free health care. There has to be someplace somehow. We can send millions of dollars overseas and we can't take care of our own people who need medical help. So it's just got to be that way. No ifs, ands, or buts. But again, thinking about where they're coming from, what their experiences have been, and what they would like to see different. All right, so from our focus groups, it was really nice. We got some direct input from community members and parents, really just sharing what their experience had been and what their perceptions were of the care that they had. And we got a good number of barriers, facilitators, recommendations, and I really liked how we were able to break it down into those different things to say it's not all negative, there are some positives, and then actually being able to voice some of the recommendations that they had for care I thought was really good. And we did have the common themes of culture and equity and communication that were mentioned frequently that kind of play into maybe some bias implicit in care. So the last section is reducing implicit bias. And so there's a lot of literature saying, okay, well, almost everybody has implicit biases. What do we do about them? And there's a number of different things that people have done. One suggests that just knowing that you have implicit biases, you're more likely to change from that autonomic functioning to a more controlled functioning, to say, okay, now I know that I have this bias, and so when I'm in a situation and dealing with somebody from that group, I'm going to change how I think about it. There's also some literature about thinking of perspective taking, like thinking about the other person, trying to put yourself in their shoes, trying to understand where they're coming from. And then another thing that people have tried is looking at positive exemplars from disadvantaged groups. So in one study, they had a number of people take the implicit association test, and then they had pictures, I believe it was an African-American test. And so they had really positive role models for African-Americans that they showed people, and then they had them take the test again, and people were generally had less pro-white bias after thinking about, oh yeah, there's all these good people, all these very successful people who are African-American, who kind of defy some of those negative cultural stereotypes. And this is from an article, this is actually an old article from 2007 when some of this literature was just coming out, but thinking about different areas to work on for implicit bias reduction. And so first, I mean, everybody's motivated to respond without bias. And then giving people information about biases, thinking about where your biases might come from, thinking about that historical racism, and then enhancing confidence in dealing with people from different cultures, and regulating that response, so switching from automatic to a controlled response, and then thinking about increased perspective taking and building additional partnerships with patients, trying to see everybody as individuals and not imposing cultural or group stereotypes on them. All right, so overall, hopefully, learned that bias is prevalent in society and in the healthcare system, that there's implicit and explicit bias, and both of those can affect interaction with patients, but there are strategies to reduce that bias. The easiest one being just to acknowledge that those biases exist and to try to change your interactions. And then I want wanted to leave you with a couple of resources. So the first one is for the IAT, so you can go and look at their tests and look at some of the research that they've done. And the other one was something that I found really interesting, is a lot of different companies are doing implicit bias training, and this is a really good training from Google. I actually took several modules on it. And it's more from a work setting, so it talks about like how you interact with people in meetings and how different things might shut people down in different ways that I hadn't thought of all of those different dynamics in work meetings, so I thought that was really good. So I'll stop there and acknowledge everybody that I worked with so far on the project, and I'm happy to take any questions.